Welcome. Welcome to Insights Equestrium and our exciting discussion today, Unintended Consequences of Digital Health Innovation. I'm Pete Howard, Professor of Practice and Executive Director of the Digital Business Institute here at Equestrium. I'm very excited today to be bringing together a panel for a lively, interactive discussion on this great topic. First, some housekeeping. We'd love to have an active Q&A with all of you online and in person for today's panelists. So here's how it works. Questions can be submitted through the Q&A box at the bottom of your screen for those of you online, or there's a QR code. No, there's not a QR code. You can just ask the questions live in the in-person audience. Okay. With me today are experts on this topic of digital health innovation. Gordon Birch, Kelley Equestrian Associate Professor in Management, Associate Professor Information Systems. Welcome, Gordon. Meize Zhu, Assistant Professor Information Systems. Welcome, Meize. And Avi Sedman, Everett W. Lord Distinguished Faculty Scholar, Professor Information Systems. Welcome, Avi. So to start, I'm curious how each of you got your interest and passion in the topic of digital health. Would you mind just giving us a couple minutes on your background with that? Gordon, would you like to start?
Sure. So the way I kind of came to take an interest in digital health, and particularly telehealth, probably actually only happened in the last couple of years. I come at this as sort of a platforms researcher. So most of my research historically and continuing is about digital platforms, and in large part the effects that they have on offline markets. And so healthcare is an interesting one because while we have had some recent disruption and shifting online, a lot of things haven't really shifted the way we would have expected them to as quickly as they did in other markets. And so that was interesting to me. More broadly, sort of historical context, I'm Canadian. And so when I moved to America, I was amazed at how sort of, for lack of a better term, things are really messed up here. And I know people, things are slow in Canada or whatever the legends and myths are, but broadly speaking, things like a lack of a coordinated, centralized approach to things leads to a lot of unique things, right? There's a lot of money at play here, but a lot of sort of dysfunctionality. And so it's just an interesting context for me, again, as a platform researcher, to understand digitization and what's going on.
That's great. We'll talk a lot today. Amazing. How do you get into this topic?
So when I started this topic, I was still a PhD student. So that was during the pandemic. I think that's when I started to notice this technology. Before the pandemic, I didn't even know the existence of such technology. I know there's some online healthcare consultation type of platform, but I didn't know such technology like telehealth, where you can actually see the doctor like online in live. It's not like just leave some questions for them to answer offline. It's actually you can like really visit a doctor in live. So I noticed this technology because it's actually because my father-in-law, he has diabetes. So he kind of need to inject insulin before every meal. And when the pandemic starts, that's when the hospital was the most dangerous places to go. So he kind of very hesitant at the beginning. He hesitated at going to hospitals to do the recheck, and then so he postponed everything. But later on, he found out the pandemic is longer than expected. He cannot really postpone it any longer. So that's when we start to look at alternatives, and that's also when I start to know about telehealth. Yeah.
Quite a personal connection.
Yeah.
And Avi, last but not least, and I neglected to mention that Avi is our lead Digital Business Institute fellow for digital health. So you have a long, distinguished background in this topic, but how did you get into it?
Unlike my colleague, I started it in the previous century. And it basically started with the casual conversation I had with the provost. When I was in the University of Rochester, I got tenured and rapidly became a full professor and then got a chair. And when you become a chair, you're invited to a coffee with the provost. So I said, look, the chair at the time, the provost, was Chuck Phelps, who has been one of the prominent healthcare economists in the US. He used to work at Rand Corporation, then hired by University of Rochester. He came from Chicago initially. And he wrote the first book on hostile management. It's kind of a famous book in the topic. And I said, Chuck, I have a question to you. I'm kind of at the top of my game, and it starts to get boring. What should I do next? So he said, look at healthcare. America is a problem. 1 out of 7 Americans is in healthcare, and it's a rather broken system. It's costly, and the results are not impressive. So I moved in, and ever since now, it's 1 out of 5 Americans is in healthcare, and I'm not sure it's way better. So I'm not sure my value was much noticed. So I decided, what should I do? I know very little about it. So I went and studied radiology. And why? Because I grew up in the intelligence unit, so I knew how to read films. And this is the most distance from patient specialty. So you cannot get infected or anything, kind of in a different room, and it's far cleaner. And it's also very intense in technology, which is what I liked. So at the time, MRI, CT became big deal, the big engines. And I developed with university programs that ran all over the country with biopharmaceutical and other pharma on educating physicians. And we work with all the major medical centers in the US, here with the MGH and others in New York City with Sloan Kettering, NYU, Mount Sinai. So I had a lot of experience working with them on issues of managing radiology business. And as technology moved on, it turns out that because of shortage of radiologists and issue of night coverage, and everything became digital, we say, why not disentangle image taking from image interpretation? So you can take the image in Cincinnati, Ohio, and somebody in Australia can do a day shift and read the image rather than wake up a physician to read one film, okay? And there started telemedicine. And it's still working out with coverage all over the map. There are some reimbursement issues still persisting today in 2023, but this was my intro to telemedicine. We've done a lot of work in the area. And then I was called one day by the neurology department in the hospital. They said, look, you do a lot of work on telemedicine. We want to start taking care of chronically ill patients with telemedicine. It's care rather than diagnostic. Okay. And there started my journey, which is still going on, and using telemedicine for chronic care, specialty care, not just emergency, you got the COVID or something, but lifetime long with cancer survivors. We started with people with Parkinson's disease, Huntington disease, which are nervous system, motion disorder kind of diseases, which takes a fair amount of intensive care over lifetime. And we did a lot of empirical studies. We published them in JAMA, in other leading journal in our discipline, in IS, in operations. What we found is a good number of time our outcomes with telemedicine were superior to the outcome with the office visits. I still don't know why, but we were judged by a third-party contract. That's how you do controlled trials. I have some, speculation. I won't share it with you now, maybe later, so I finish the introduction. But then we were called by people from other departments, and we looked at diabetic retinopathy, which is a complication for diabetics, loss of eyesight. We did a lot of research on chronic migraine. The results were always the same, pretty much. Equal or better than office visits, which is kind of puzzling. But this was very encouraging, and we still do some work now on other conditions. And we did clinical trial in a very organized, systematic way. A lot of what you see now in telemedicine is hospital put it and they think because they talk with the patient gets better. But I haven't seen many systematic studies, the whole thing works, or there's no need to come to the clinic anyway, just adding more work for the physicians. Jumping for today, I've been nowadays looking at integration of AI with telemedicine for specialty care. If we have time, we'll talk about it. If not, we'll do another event. And also using AI with physician decision-making, which is another aspect there.
Which, by the way, if I could jump in, that's a critical item we hope to get to at the end. Let me ask you this, Avi. You're kind of leading into the overview of telehealth, telemedicine, interchangeable terms. But I know you could kind of ground the audience on the background and what it is. And I think you have a couple of slides. Would you like
Yeah,
to jump right into that?
before I do it, I have a question to the audience. How would you define good medical care? I want to hear your opinion. What is a good medical care? Please.
Health outcomes for people that are sick, that are improving, and prevention of illness among those people who are well.
But that's something, 10 years down the road.
Yeah.
But if you go see a physician, how do you feel it was a good encounter, please?
That the patient feels better.
Hmm?
That the patient feels.
You feel better.
You feel better.
Okay, that's one.
Continuity of my relationship with my physician and they having enough time to practice rather than fill out all these tablets that they're saying is a huge problem.
Okay.
Communication.
Communication is important. Go ahead, yeah.
I shouldn't be going back to the physician again and again.
Either you hate them or they kill you. Then you don't come back.
No, it's not about hating. I just like it's a lot of
Stay alive and you don't. That's good. You problem solved, right?
Yeah.
You go to mechanic, you fix the car. Any other comments?
Just following up on that young gentleman's comment, just taking the excess amount of work that has to be done by the patient, by the family, to make it simpler. Healthcare is difficult as a patient or as a family member, and it shouldn't be.
Okay, somebody behind
And
you.
one more in the corner.
One more. Availability. Availability.
Availability. When I came to this great town and I want to see a dermatologist, I call MGH, can take my own opinion. And I say, any physician. So, okay, in 7 months, you see a physician. 7 months, okay? It's a city supposedly with a lot of care. The night before, they called me. They said, the doctor is sick. We canceled the appointment. Okay, I won't talk more, but get going. I also was involved in developing Clicks, which has been still in use in Israel, about 70% of population of the electronic medical records. We two are the partner, are the small part in it. And I think it's way better than anything you see in the US. In the US, the main objective of electronic medical record is generate income for the hospital. Your clinical outcome is okay, but it's not the number one objective. Unfortunately, yeah, I want to talk a little bit about telemedicine, and by the time we get the slides,
We will.
we're
we
all
will.
set.
And then we'd love to get into
Okay,
the
this
Zoom
slide,
paper.
it's hard to see the detail, but when we started looking at Parkinson patients, we want to see how much access patients have to Parkinson expert, okay? It's a complicated disease. Usually it's a terminal disease. Some people live longer, some shorter, but there's no cure for it. That's why it's called a chronic disease, but we can help the patient have a longer and a better journey. As it turns out, in the map that's based on CMS data, government data, almost half the country, physicians are unavailable in most of those countries. You can see by the color codes, and that's a huge issue. And with telemedicine, we can cover a lot of rural area with this specialty. So telemedicine basically has 4 elements. We want to click and see the patient. One option is you call the physician, as some of you mentioned, online, say, I'm coughing, I'm bleeding, I have headaches, I'm depressed. Give me some immediate solution. That's one way that many of you have been using it. Another dimension is basically when it's called physician to nurses or physician assistant or nurse practitioner. And nursing home use it a lot, so the physician is not on site, but the consultation is done remotely. You don't call individually, but the institution is calling for help. That's a very common practice as well. Another option is what we call physician to specialist, in case of a stroke, okay? If somebody in emergency room and they're calling a specialist to say, how should I treat this particular stroke case or emergency accident or whatever. So we're calling a specialist to address the case. And then there's also what we call specialist to specialist. As a radiologist, I'm calling an oncologist saying, this is the finding, the patient is having remission, the patient is getting deterioration. So there are a lot of dimensions for telemedicine, they're more than that, but it's not just one way you calling the patient. Is that clear? And each one of them is its own pros and cons. There's a lot of interesting trend in what we call DTX, digital therapeutics, which means I give you the care directly to the patient at home or in a place of residence, whatever. And some of you know, like the Apple Watch that many of us carry, that have life signs, can give warning of deterioration. If you fall, it's called an ambulance. So there's a lot of care, but there are many other dimensions. There are people who go with rings, some of you know the rings, the Noon and other ring product. And I can see irregular heartbeat, etc. And I can provide you care, say take the medication, send you a message or call somebody to give you help. And that is a big bonanza for the pharma company, work with AstraZeneca and other. Why? Because so far, a pharma company was a mile away from the patient. I develop a drug, it goes to the benefit management company, goes to the insurance, go to the pharmacy, then you swallow it or get injected or whatever. But I don't know you by name, I don't know who you are, I have no follow-up at the individual level. With providing DTX, I go directly to the patient, bypassing the whole supply chain. So I know the patient, I can sell them other treatment complementarities, and I get more data for myself. So a lot of VC money has been going to digital health on those dimensions. Mental health has been the number one, and people of all ages have been using it. These are times of stress, and COVID just added to the complication there. And we see a lot of effort in addiction treatment there. Primarily, it's addiction to drug, alcohol, cigarettes, a different dimension that people are using remote telemedicine care. And the advantage is you can get care from out of state, from many different places. There are issues, we don't have time to cover it, of reimbursement. Not every time when you cross state boundaries, you know, you sit here and you want a physician from Oklahoma, she may or may not be reimbursed for care because that's the way the medical system operates. So the economics is a big issue in kind of putting all those things together. But addiction management is kind of one of the number ones, but there are many others there. This is a chart that shows you part of the complexity of our healthcare system. There's argument whether it's the best in the world. It's debatable, but we're definitely the most complex one. And I will leave it at that, and maybe you two want to talk about your research on kind of the unintended consequences.
Thanks, Avi. That was a great setup for the complicated landscape, right? So, Gordon, Maisie.
I think Maisie's going to kick us off here, but let me just bring up the.
Yeah, so this is a link that we post about our paper. So if you want to know more about this paper, you can just scan the barcode. So basically, the paper started still just after the pandemic started. And at that time, I started to be interested in the telemedicine. And I know that in the information systems literature, there are a lot of study about digital disintermediation. So basically, in the past, for example, like in the past, you go to your local grocery store, you go to your local shops and purchase some, let's say, office suppliers. Maybe you go to Walmart or Target. So where you go to most of the time depends on the location. Right. But later on, if there are some e-commerce or online platforms, maybe you choose to purchase from Amazon rather than your local grocery store. So you see there is a shift about people's demand and where people purchase. Similar idea could be applied to the healthcare domain. So that's why I started to have this idea. So I was thinking, telehealth, okay, now people can use telehealth. They can feel free to choose the physicians, even if the physician is not nearby, right? And in that case, how does that change the healthcare domain? So that's like a very broad question. And then I started to look into the telehealth usage, and I found out even before COVID, the usage of telehealth doubled almost every year. So starting from maybe 2015, this number doubles almost every year and increase really fast. And many states, they are trying to encourage usage of telemedicine, mainly because they want to provide their rural patients better healthcare. higher quality healthcare. That's why many states try to develop a lot of policy, a lot of regulations, trying to facilitate this process. Right. For example, they want to give the physicians licensure to let them conduct telehealth even across state borders. And they also try to make the telemedicine reimbursement process equivalent to the in-person treatment. That's the telemedicine parity law. So many states kind of try to make a lot of efforts to make this possible. And that's the initial purpose of doing telemedicine. So we are interested in that, so we kind of look into this problem. And after we researched into it, we found a really interesting phenomenon, and it is also unexpected consequence of the telemedicine, which is we found out when a state starts to adopt telehealth, actually the rural patients, they are more likely to choose the physicians from urban hospitals, those big hospitals who have better physicians, who have higher quality physicians, and they that will replace their choice for the rural physicians. So that's a phenomenon we found, and that makes there is a significant change from both the services and the payments from the rural physicians to urban physicians. So we found out after the adoption of telehealth, the urban hospitals, physicians, they are actually making much more money. They receive more patients, they receive more payments, and compared with these urban big hospitals, the rural hospitals, they are actually losing patients. They are losing this income from these patients. So that's the biggest finding of our paper. And of course, there are some heterogeneity. For example, generalists, the impact on generalists is much smaller than specialists, and is mainly because people's needs for high quality special needs is higher for the rural patients. And we also found if the hospital is more ready for the telehealth adoption, then they may receive more patients. Yeah, that's the big idea.
Yeah, so and I can just elaborate a few points I think that are pretty important here. So the first thing is so Avi talked earlier, there's a lot of evidence that telehealth actually helps. It works. And oftentimes it's even better than seeing somebody in person for a lot of possible reasons. One thing that our study is trying to highlight actually is spillover consequences. So thinking about not what's happening for the patient that's maybe seeing a telehealth provider, but what's happening to other patients or the providers who are no longer getting those patients. So we're trying to document those spillover effects. And it's not something that's received a ton of attention previously because it's actually hard to think of a broad ranging sort of national study of these things where we can reliably identify people that are seeking telehealth services, and they're doing it in a way that it's kind of we avoid issues where, for lack of a better term, self-selection. So I'm trying to avoid getting into research terminology here too much, but basically we want something that can approximate a random assignment of people to healthcare access modes, right? Obviously, we're not randomly assigning people in our study because we're just using a bunch of historical data about where were the funds flowing, basically from patients to providers. This is coming from government data for the most part, as well as some private claims data. So what we end up doing to be able to kind of get at what happens in sort of a random way is we examine states joining what's known as the Interstate Medical Licensure Compact, the IMLC for short. So states across the US have been gradually entering into this compact. And what it is all the members, they basically streamline physicians' ability to get licensed in all the other compact member states. So they file one application, and it all gets processed at the same time. And it's overnight, I'm approved, and now I can practice in 35 states instead of just mine. And it used to be they'd have to apply one by one. And there'd be heterogeneous requirements in each state, which would create challenges for the physicians to kind of meet all the documentation and the requirements, et cetera, right? And there'd be different timelines and different fees. So all of that gets really streamlined now for the states that are belonging to this compact. And it means that physicians are now much more likely to try to practice across states. So when a state enters into the compact, this is like a shock. Now all the providers that are located in that state, it's easy for them. They have a better incentive or a lower cost to become a remote provider because their market has expanded massively overnight of potential patients that they can reach. Okay, so we look at physicians in these states as their state joins, what happens to the number of licenses they hold? And we show it goes up a lot, right? Essentially, the physicians take advantage of this new ability to practice across state lines. If we look in private claims data that we have access to, fortunately through our econ department, which subscribes to some private claims databases, we can see that. We see increases systematically in people making use of telemedicine services once the states join, right? And ostensibly, this was a big reason the IMLC was created in the first place, was to facilitate telehealth adoption, right? As Maisie mentioned, not only are states pushing this, so are a lot of large medical organizations like the AMA, et cetera. So we had some conversations on the side. So I talked to some people from the Minnesota Department of Health, because I was actually in Minnesota where Maisie did her PhD, like when all of this started, to kind of have conversation with them about what are they thinking, right? And get their reaction to some of our results. And essentially, it kind of blindsided them, which is really interesting, right? Because we've heard for a really long time about how telehealth services are great, they advance access to care, and we should just push them so everybody can have them because it's obviously a good thing. But we're not stopping to think about like, okay, what's the counterfactual? What would have happened to the various providers in the ecosystem if we didn't have telehealth? And the thing they weren't recognizing is, well, the patient was previously going to, make the lengthy trip in their rural location to get to their local provider. And they don't have to do that anymore. And they can opt to be remote and talk to somebody urban and a specialist and the best in their field and do it from their house. Well, they're going to do that. But then the question is, what happens to that rural provider? They're clearly losing revenue. And we document this in the paper. And this is concerning for obvious reasons, right? Like they have less revenue, they have less resources, they can't deliver care as well. But also because there's already a huge strain in the American healthcare system in rural locations that a bunch of rural hospitals are already going out of business. Like it's already a big problem before telehealth is really there because we have people moving to urban cities more often. There's bigger concentration in urban locations. Rural hospitals are struggling. And this is basically just adding to that. It's compounding the problem, right? It's pushing revenue away from them. And you might say, well, why does that matter? Okay, let patients go where they want. Well, my question to you is, what do you do when you have a heart attack? Are you going to log on to the internet and get help from your provider over a broadband connection? No, you're not. You're hoping that somebody can treat you right away, very quickly, locally. And as rural hospitals go out of business or they struggle financially, that is not an option anymore. So this is not an intelligent solution, is the point. Like we need to be careful. So the main message of this paper is not don't do telehealth, obviously. The main message is it needs to be an integrated approach, right? There needs to be policy that comes with this, subsidy of some kind potentially, things to keep the rural providers in business and capable of functioning to deliver those things. Okay. That was a bit of a rambling
Not at all.
dialogue, but
It's a very important insight, yeah.
Okay, so this is sort of the main takeaway, why this is important.
I mean, to me, it's almost like the Amazon effect, right? With retailers, the large, as you mentioned at the front. Yes, exactly.
There are some interesting things that I like very much about the research, because when we start publishing our paper on telemedicine, we predicted it will happen, but we did not have the empirical data that you provided.
We motivate our paper with your paper.
Yeah, no,
so Avi had some,
We all get citations, thank
yeah,
you.
you have nice like analytical,
Yeah.
theoretical
Yeah.
work, and we're basically showing it's true.
There are other things. The first problem we saw was in Shanghai, in China, about 6 years ago, when China put a regulation that physicians in Shanghai cannot do telemedicine. Because the people of Shanghai say, we pay for the medical school, we pay for the students, and then the rich people from all over the big China state, 1.2 billion people, are calling, and I can see a physician 2 years from now. I died twice. So they say it's unfair that we subsidize. The same thing is in Boston, okay? The target population for Mass General, okay, is they want to be like Mayo Clinic or Cleveland Clinic or MD Anderson, get the rich people from the other countries to come to Boston, where we stay at the back of the line because they pay cash, they don't have to argue with Medicare, Medicaid, and so on. So this is the dream. Luckily, it's not working as well as planned for us, okay? But that generates on us a huge externality as the people in the big city, all of a sudden, were being pushed back, in this case, by rich people from other countries or from whoever in the US. The other point is the rural hospital are kind of using volume, and it makes it less attractive for physicians to go outside the big cities, which is already a problem because most of specialists in the US like to stay in big city close to medical center. There's another unexpected income element of telemedicine is this. With co-payments for care. Why do we have co-payments for care? Why do you think? Why do we put co-payments on visits?
To make the patient have a stake in essentially ration as a result.
To ration. So it's to reduce demand. Now, when I put this telemedicine, does it increase or decrease demand?
It increases.
Increase demand. So I'm countervailing because coming and parking and driving is more than $30. It's a payment. So now I'm making the physician more accessible. And when I talk with many physicians, it's killing them literally. A patient send them an email, okay, and saying, I sent you an email 2 days ago. Where's the response? Okay. I expected you to renew my prescription. You say, I haven't seen you for 5 years. I don't know if I can give you a renewal. Okay. So that generates a lot of, because telemedicine is not only with Zoom, it could be with email, could be with chat, okay, et cetera, et cetera. Many channels that we can address it. And the problem is this. We've seen a lot of studies coming around different dimensions how patients choose it. But patient expectation for telemedicine is for much faster response than if they come to the doctor and they say, you have to wait for a week. I send you an email. Why do I take 3 days? So some hospitals are start charging for emails. They say, I have to do research. I put an answer in writing. I'm legally liable. Okay. So the whole medical system, there's a lot of research going on. If I have 40 hours a week of a physician, how much of it will be face-to-face and how much will be telemedicine as per specialty, okay? Our son, I can tell you something interesting. It's Boston. Had a biopsy, skin biopsy on the leg. And they say we need to take a big cut out to clean the margins. So they cut the margin, put a lot of stitches. 3 weeks later, he called, when do I come to get the stitches? No, we give you a link to YouTube. You can do it yourself. Literally, this is one of the big name hospitals in here, okay? So luckily it's good with his hand that he could reach the place he did on his own. So telemedicine has a lot of unexpected outcomes, okay? Sooner or later you do like, he's a kid for open heart surgery, you can do it at home, okay? Who knows? But it's really changing the way things are happening. Yeah.
And can I just mention, actually, this is worth noting. So we actually had results in this paper that we deleted in the review process because peer review is great. So there was nothing wrong with the results, but they wanted a clearer story. So we took this stuff out. So we actually looked at essentially quality of care for inpatient services for urban providers. So basically, once the urban providers start picking up all this remote traffic from other patients, we actually saw declines in quality of care on patient satisfaction surveys.
Because it takes the time away.
Exactly.
Yeah.
They're paying less attention to the face-to-face patients as they're getting more revenue because they can scale more online.
Yeah.
And there may be sort of another externality actually for inpatient care.
Yeah, there's also issue of protocol. We work with one HMO, and the question, to give an example, is gynecology. Women take all kind of drug pills as contraceptives. So should they see the physician physically once every 6 months, once every year, once every 2 years? Because the rest they want to do it online. Okay, I would like a renewal every so many months. And there's no literature to tell us what's the optimal. It should be every year for every patient, or some patients you can say come every 2 years because of age, medical history, or some you say, or mental health, antidepressant or whatever, you know, all kind of drugs. So the issue is I can do something with telemedicine, but there's not enough know-how in the field to develop the protocol. When should I see you physically? When we did the studies on the chronic diseases, we said once a year, it was arbitrary decision. You should come see the physician in place, and the rest of the visit, you should come, you can do it online, unless there's deterioration. The one interesting benefit we found is that in general, neurologist expert was about visit or chronic migraine was 30 minutes face-to-face, but it goes down to 20 minutes with telemedicine. So I'm getting 50% more capacity out of the physician when she's seeing them online versus coming to the office. When you come to the office, the hardest part for the physician is to get you out. Oh, doctor, I have one more question. Okay, here's the prescription. Yes. What is the copayment? Where's the pharmacy? By the way, I have another, because you're waiting for so long, you drive to the clinic, you have a laundry list of questions. If the physician is literally on your home screen, you say, okay, I can call again and ask the other questions. The physician say, no, I have another patient blinking, conclude, move on. So basically, patients were equally happy with 50% or 30% less time, which give us a lot more capacity. So that's the upside. The downside is I put higher volume on the physicians. And it's not clear how Medicare, Medicaid, CMS will pay for it. Will they pay the same amount or cut the amount? So the whole reimbursement issue is still up in the air. And now, as artificial intelligence coming to the play, it makes the play even more complicated.
So if I could jump in following on the inequity issue or the disparity of care, how about the socioeconomic implications? So Ivy, you and I have spoken before about underserved communities that might not have laptops, might not have high broadband internet connectivity or private places in their homes to have a telehealth visit or telemedicine visit. And especially with urban healthcare providers declining, and people depend on those that can't afford or don't want telehealth. What are the implications there? Amazing.
So I think in general, there are many different types of telehealth. As you mentioned, maybe at home, people don't have enough bandwidth or good enough network. One existing way to solve this is that you can go to some local initiation state, like CVS. They already incorporate such telehealth services. And in rural area, you can also go to some local clinics where they can help you get connected with the urban hospitals and receive the telehealth medicine. That's one potential way. And also, I think this is so far, it doesn't really help with the rural hospital or clinics situation, because most of the time when they are working as an initiation station, they only receive a very small amount of payment, such as maybe $35 for one-time visit, and that doesn't. So most of your treatment payments still goes to the urban big hospitals. So I think one way to kind of help the rural hospitals, maybe they can find some other ways to collaborate with the urban hospitals. Maybe they can finish the treatment together. And for example, the initial telehealth consultation is done by the urban hospitals, but the follow-up treatment could be finished together with the rural hospitals. In that way, the rural hospitals may receive more payments.
Hey, fascinating ideas for budding entrepreneurs out there, right? Business case. We have a question, Fred.
So your study appears to see a problem in redistribution of demand. But I've got kind of two ways of thinking about that. I'm curious how you think about it. Because if I break it apart, there's a part of demand that's increasing because it's easy to get access. But then there's another part that is redistributing demand. And is the real problem that it's being redistributed, or that we don't have enough specialists in the first place? That we've turned local markets into national markets or broader markets. And we now uncovered the fact that, we never served them before, but now we should be, and we just don't have enough people. What's the real problem there? And then the same if I split them up, if I say now I've increased the demand, the accessibility has increased demand. That's the other side. Is that a problem, or is that once again a shortage of supply, or we have to put some mechanisms in for it?
It's more complicated because hospital traditionally have what you call geographic monopoly.
Yes.
You want to deliver a baby, you're not going to do it with telemedicine. It's somebody within a half an hour drive or whatever. Same thing with heart attack or any emergency. Okay. On the other hand, when the market becomes more efficient, so to speak, then there's a phenomena called the economy of the superstars. So everybody goes to if everything else being equal, I go to the one with 5 stars, the better name, the big name hospital. And those who are not superstar get pushed out of the game. You see it in colleges, you see it in the medical center, and that's an issue. So, but some hospital, the right strategy for them is to say, all we do is garden variety. We do, certain things, and the rest we affiliate ourselves, as many do. We send you to an affiliate like the Cleveland Clinic or the Mayo or MGH here that will take care of the complicated cases. But the day they are the garden variety, we can do well.
So in other words, even the structure of hospitals might change. So you'd have.
It's already happening. Yeah, you see it even here in this area. Yeah.
But is there an overall, I'll call it shortage of specialists?
Oh yeah, huge. If you wait 7 months to see a dermatologist, and the visit is 7 minutes to see a doctor, when you come in naked, it's 7 minutes, in and out, okay?
Yeah, we can be the Boston people say, oh, it's so bad that we can't get any access. But there was, people all around the country that couldn't get access before. They're rural, they're poor, isn't it about time?
No, it's more complicated.
Right. Yeah.
No, because telemedicine is a huge downside for the physician. Besides the pressure on doing more cases per day, it's the issue of licensure. When you switch from one hospital to the other, they need to do due diligence on you. And ask you, Robert, which hospital did you work with? Say, I was in Beth Israel here in Boston. I called Beth Israel, record is clean, I hire you. It's more than that. It takes months, but if you say, I served in telemedicine 15 hospitals, you know what? I don't have the money to call 15 hospitals and get all the paperwork, the affidavit. Call another place. I'm not hiring you. So I saw it in radiology clearly. People lost a lot of market value by using telemedicine to serve many hospitals because they could not move. And nobody told them, because to move, you need clearance from everybody you consulted with even once. There was no abuse, there was no racism, whatever, it's a long checklist, which is very expensive to do. So they kind of get them stuck where they are. So many physicians don't like to be in the business as a result.
I think the point is, yes, people are, the reason they're switching to like an online specialist in an urban location is because that's better for them. Clearly, like they had higher transport costs, less access, and this is solving that friction for them, and the consumer is going with the thing that reduces their friction. Nobody's questioning that. I think the point is, specialists, generally speaking, don't want to be operating in a rural hospital, so they don't locate there. So as a result, when this choice happens, this friction goes away, people stop going to the rural hospital and they go where the specialist is. And that has a revenue implication. And the point is, we need a way to maintain the sustainability of rural hospitals, because they do a lot of things that happen in person.
Well, that's the only thing I'm getting at is that if that is, as you say, it's more complicated than that. And I could think of other solutions like specializations, other market mechanisms that
there are market mechanisms potentially. Yeah.
One says disruption is happening, so we got to find mechanisms to stop disruption happening. I go,
no. It is not to stop disruption happening. We are not in any way suggesting that we want to stop rural patients from seeing an urban specialist. That's not what we're saying.
The way they operate now.
No, not what we're saying.
Change.
I don't agree with that. We didn't say that. What we're saying is we want rural hospitals to not go out of business.
Okay, then maybe they have to change their business model.
Sure, exactly. Exactly the point. And that may involve some policy solution as well to help keep them operating in the meantime, so they can figure that out.
But you see it with the case of Amazon that you mentioned. So clearly, they're killing many retailers. Okay.
Just to add to that, I mean, I think rural mechanisms are in place. We get letters at home all the time with ungodly salaries being offered for just basic physicians in rural or undesirable locations because they can't attract physicians.
Yeah.
My question's different though. My question's around the differing legislative and policy that's in place for certain healthcare, particularly, let's say, women's health across in the different states. So when you talk about patients who travel from state to state to state, how does that work? Right? Because let's say there's procedures or policies in place that ban certain procedures in one state, but are perfectly legal in another state. What implications has that had on the adoption or limitation of telemedicine?
It's a bit more complicated than that for the reason behind your question, of course, which you kind of camouflage it a little bit, okay? Yeah. And the complication arises from the fact of reimbursement. Okay, and what does the insurance coverage? So during COVID, everybody became very friendly and allowed a lot of cross-border consultation and so on. And now they're kind of going back to the old model and start cutting it out as much as possible. Oncology care is just one example. We used to get a lot of out of state and so on, and now they want to cut it out. Part of the reason is to protect the local franchise, okay? And women health is another example. When state says we're not paying for, you go out of state, you're on your own, out of pocket. For the same reason, they want to enforce it on the citizens of the state.
And there are a lot of ambiguity at the moment because there's some states that are talking about if you go to state and get a procedure that we call illegal here, well, you're a criminal potentially. That hasn't been figured
For
out yet.
executing the procedure, yeah.
Yeah, and the physicians on the other end may be concerned about that and not want to treat you because they're worried about legal liability that's in flux. So I don't know.
Legal liability is it?
I don't think it's been
It's up in the air.
exactly. And when you have ambiguity, then the physicians are generally going to be like, no.
Yeah, so Professor, you mentioned about digital therapeutic as one of the next futures. You mentioned about digital therapeutic as the future change that will happen. So I have a question that in telemedicine, where you seek consultation from a doctor, and then when it's digital therapeutic, you can purchase any type of medicines online from the factory. So isn't it contradictory? Like people without prescriptions can also purchase any type of medicines on the business itself.
The idea of prescription stays. The question is who writes the prescription. There are a lot of what we call lifestyle medication, depression, Viagra-like medication, and so on, that people now can buy them online. There's a whole industry that supplies them. Antidepressant, now the government is putting a strong arm on it right now because they think it's abused. And the discussion with the physician online is not really substitute to an office visit and a physical exam. And they can put patient in harm's way. So there's a lot of discussions around it. At the moment, it's still legally, it's still available. It's a huge business. So it's kind of, you call the physician, they ask you supposedly a few questions, and then you get there what you call the lifestyle medication that you were asking without going to a visit. And that's a huge kind of a side business. The government has been for the last few months trying to clamp on it a little bit because of, there's a lot of abuse. Because one of the issues, you can shop for the same drug simultaneously from different places, though there are database against it, but people find loopholes. Yeah.
I have a question about outpatients. Your research, there's been a natural shift to outpatient settings and use of medication therapeutics anyway.
Yeah.
How do you keep that variable controlled when you talk about the impact on rural hospitals? In other words, there's already been a natural migration to using outpatient services for many things and avoiding a hospital inpatient stay. Is that obfuscating your conclusion or making it a little more complex? Because in my mind, looking at things like addiction medicine or physical therapy, for example, all sorts of things that you're moving patients anyway out of hospital settings and quite frankly away from doctors to other specialists and practitioners that are cheaper, to be quite honest. So we're seeing that on top of these phenomenons that you're describing. I just think it might be variables that you'd have to take into account.
So we're getting into research design here a little bit for our study, but basically we're looking at state staggered entry into the IMLC, which means we're looking at discontinuous shocks to the prevalence of telehealth. So you're talking about a general trend, which may be there. Unless we think that that is something that is discontinuously shifting the same time that the states are joining the IMLC, which I don't think is plausible, then it can't really explain the spike that we basically see in revenue shifts that happen from one year to the next. But I don't disagree. That's probably a general trend that is there.
Let me answer your question. We've been doing a lot of research on something. It's called in general aging in place. Okay. And Hopkins was the first to come with the concept of hospital at home almost 20 years ago. And many hospitals are already doing it, except Hopkins itself, because they will lose a lot of revenues if they're not on site, okay? And it's very expensive, and you send a nurse to the patient home, and then there's a dog she doesn't like, she comes home, you lost half a day, and there's no billing, okay? Just one example of traffic jam or no parking in the place, or they don't like the neighborhood or whoever the housemates of the patients are. So there is a slow move, even in Boston. I know some pilots of doing hospital at home, which does make sense, but Strangely enough, it's moving very slowly. I think we still have to kind of find the right model or right modality to do it. As you mentioned earlier, addiction is very successful. Physical therapy has been phenomenally successful doing it remotely. As I mentioned, in diagnostic imaging, medical imaging has been doing it for a long time. Radiology, they give patient sensors at home. They can put 2 fingers on an iPhone, and I can get a very reliable EKG of the patient, kind of rush to the hospital or stay home. So it's moving, but there's a lot of technology that still has to be in place, and as well as economic model that makes it viable for the providers and for the insurance to do it. The problem with the insurance company, they say, we'll pay for it so long as you prove to me that long run, the life cycle cost per patient goes down. And that's very complicated research to do. Otherwise, the so-called private insurance, the Blues and others, will not pay for it. So the question who pays for telemedicine is still remaining open, because they want to see economic value or quality of life, if quality of life kind of added. But the proof of it long run is complicated.
We had a question here, and then we'll take one on from our audience.
Yeah, not a century ago, but 15 years ago, I was visiting critical access hospitals in northern Texas, southern Oklahoma.
Okay.
And the heat map for the opportunity or the problem first was it was the heartland of America. From a stakeholder perspective, what has changed in 15 years as we're trying to get to a complicated win-win? But at the next level, I admire the globalization of the three of you. What do we take from all this great data, and where do we take it? Do we take it to Western Europe, or do we take it to the emerging world? What's next?
Yeah, that's a very interesting question. I think I'm from China. I think at least in China, it has some similar questions. So like in the rural areas, the physicians' quality is not as good as urban hospitals. I guess it's probably this phenomenon is a common phenomenon in many areas. And therefore, like whether our findings could be generalized to other areas, I think depends on, like, for example, how do we use telehealth? Do we simply use it as a tool for the physicians to for the patients to visit the good quality physicians, or do we want to incorporate other economic models? So also adding to the previous question, I think it's kind of related to the mechanism of the telemedicine, right? The reason that telemedicine can bring a lot of revenue to the urban hospitals has like different reasons. It could be a substitution for some type of treatment. We also found that, so for some patients, if they are able to find some much better like physicians, even if they are able to find similar physicians in their rural hospitals, they prefer to go to urban hospitals because they just trust in their quality. That's a substitution effect. Besides the substitution effect, there could also be some gateway effect. Like even though initially you are an outpatient, you are just doing a consultation, but later on you may become an inpatient to the hospital. And just because you started with the urban hospital's physician, you are more likely to become an inpatient of the urban hospital. So the rural hospital, they are also losing a part of the patients that like maybe they still are able to receive this treatment from rural hospitals, but just because they started with the urban hospital, they prefer to continue the inpatient treatment there. So like go back to your question. So I think probably this result could be generalized to other areas, and also these mechanisms like why telehealth could bring a lot of income revenue to the urban hospitals. This may also be, we didn't really look into the data, but I think in some areas, maybe this mechanism also exists.
Yeah, I could answer the question. It's a matter of structuring. We just finished a paper to be published in the next few weeks on telemedicine in dental care. And dental care has been an issue in the rural America. You'd be surprised, the most common procedure For the rural area, the depressed area is extracting all the teeth from the mouth of the patient. People don't brush their teeth, they drink Coca-Cola before they go to sleep, and it's hopeless cases, okay? You have to take all the teeth out. It's as bad as one can imagine. And what we find out, very much in line of the research we had here, is that the optimal strategy is for the urban hospital to have regional service, like mobile unit or region, which add as funnels, and they provide the basic care at a loss, like cleaning, filling, and so on, and all the extraction and surgical procedure, they refer to the urban hospital where the specialists are. So while I lose money on the regional hospital, on the suburban hospital, this is a funnel that drive patients into my main facility where I make the more money on the, because you make money in medicine only when you hold the knife, okay? So when I do the procedure, that's the reality, okay? So just the office visits and all this, you lose money, but you keep it as a funnel. So you make sure the complicated cases, the more profitable, so to speak, come to you. And you provide also, you improve equity and access and so on. So a lot of good social justice elements to it, but it's paid by the fact that you capture all the complicated cases for long-run care.
Well, we're at time. We have a lot of other questions, and I think we have content for another session in a few months, particularly on AI. In fact, yes, the last question we have. In fact, if you have a 30-second response to tee up to our next session, what are your thoughts on layering predictive analytics and by extension AI on telehealth, particularly in the acute setting? Anybody want to take a rapid answer to that?
Can you repeat that last one?
What are the implications of applying predictive analytics, and I would add AI generally to that, to telehealth, particularly in the acute setting?
Acute, I see. I mean, it's pretty interesting. If you think about like the richness of data you can actually capture through a remote visit. So I'm talking about the specific mechanism or mode where a patient sees a doctor and you have some video connection or something like this. You have super rich data there, right? So we have a lot of interesting examples of like using video interviewing in recruiting and people throwing the recording of the interview at some AI to predict if this is going to be a good employee. Now, there's obviously a lot of reasons that might not be a good idea. And there's laws in Illinois now that say you have to tell a candidate if you're doing that because that's like kind of creepy. But in a medical context, you can think about like we're capturing so much information, we may have a much better ability to diagnose through those casual conversations. And we have, for instance, call centers like United Health Group, I know, for calls they take with patients, they monitor for signals of like early onset dementia and Alzheimer's based on speech patterns in the interactions. Now, it was a question, why is an insurance company doing that? Maybe they're not pro-social, but the point is you have all this rich data, which creates a lot of opportunity, right? So I think there's a nice actually complementarity between these two things.
Can I make one quick announcement? Yes. Just as a commercial break. Those who are interested in telemedicine, the health management program is celebrating 50 years, and we'll have a national conference on Friday, April 5th. And we expect about 200 participants from all over coming. We got an amazing array of speakers. And Ned, maybe you can make quick comments on that. Yeah.
We're very excited about celebrating as Avi said, celebrating the 50th anniversary of the start of the health sector management program back in 1972, the first 11 graduates in 74. We had 74 graduates last May. So we've been growing. And with Avi's support, we have a great conference co-hosted by DBI on April 5th.
The conference will talk about the future of digital health. So if you learn about the past, if you want to learn about the future, come to our conference in April.
Very exciting. And you'll start seeing emails on that. We're co-sponsoring and very excited. So thank you to our panelists. Thank you very much to our audience in person and online. It's been a great fast-paced conversation. We could keep going, but we're at time. So have a great day. Thank you.
Thank you.